move on. Okay, so we have hypocalcemia. Again, you're not going to have this this diagnostic overview algorithm in your version because this is only in the newest version. We'll have diagnostic algorithms for the phosphorus chapters as well that would not be found in your copies. So let's go through this overview and then go through the specifics. You still have all of the specifics in your version. So I still think, you can follow the argument. This is just the visual. So calcium is low. The next step in diagnosis is to really, just like in hypercalcemia, figure out what PTH is doing. PTH, your master regulator of serum calcium. And in this scenario, well, let me make the point because it's an important one. Calcium is unique, both hypercalcemia and hypocalcemia. I don't think I made this point in the start of hypercalcemia. It's very important, especially in hypocalcemia, is unique in that usually disorders of calcium are not disorders of calcium deficiency or excess. Okay, let's contrast that with potassium. When you have a hypokalemic patient, you can have intracellular shift, but most patients with hypokalemia have a K deficiency. Most patients with magnesium, hypomagnesemia, have a magnesium deficiency. Most patients with hypophosphatemia have a phosphate deficiency. Calcium is different. The reason being is that you have this immense pool of calcium, right? You can be deficient in calcium and maintain normal calcemia for a long time. That's why patients that you see, I usually use this clinical picture. Patients that you see who are CKD5 for decades with a creatinine of 25 and no medical care, they can present with hypocalcemia, okay? That's because they have years, maybe decade, of calcitriol deficiency and impaired absorption of calcium from the gut. Eventually, they get so much osteomalacia that they do have such a profound deficiency, they cannot maintain a normal serum calcium. But that's an exception. If you see most of the patients in your nephrology clinic, CKD5, with sustained calcitriol deficiency, which you have not supplemented, they're not getting hypocalcemic. Why? I mean, they're calcium deficient from sustained relative calcitriol deficiency, but because they have this immense skeletal pool, they don't get hypocalcemic. Okay, so you need sustained deficiency in order to manifest that. That's distinct from hypokalemia, hypophosphatemia, right? You can manifest those with deficiencies on the order of days. You need years of deficiency in order to manifest hypocalcemia. Okay, many times hypocalcemia and hypercalcemia are just disorders in compartmentalization. Okay, so it doesn't take long at all for you to develop hypocalcemia if you have a low PTH. Okay, everybody get that distinction? All right, so again, the diagnostic tree really centers about PTH activity, and when PTH is high, that is going to be the normal response to hypocalcemia. Why? Because calcium is not binding the calcium sensing receptor. The calcium sensing receptor inhibits PTH release. We've gone over that, and hopefully I don't have to draw that any more times. Okay, so PTH high is the normal response to low calcium. Why? Because calcium sensing receptor is not binding sufficient calcium. Okay, and so again, these diagnoses will fall into that. A classic one would be post-bisphosphonate. You see that a lot, right? You see disorders of calcium in the onconephrology, consult, right? So it's always pretty top of mind when I see a calcium disturbance. I just kind of go through the med list. Okay, this is a breast cancer patient. Breast cancer patients with osteolytic lesions, or even not, when they have bone mets, are often getting bisphosphonates. because it shows improvements in clinically relevant endpoints in that population, or a multiple myeloma patient, right? So post-bisphosphonate or post-denosumab would be in a scenario in which PTH would be high and the patient would be hypocalcemic. Some patients who have vitamin D deficiencies, we'll talk about pseudo-hypoparathyroidism is a unique one as well. We'll talk about that. And then we have those cases in which PTH is just not appropriately elevated, right? It can be inappropriately normal, similar to our discussion around hypercalcemia, where PTH is inappropriately normal in that scenario. And so we'll go through these diagnostic possibilities. We'll focus a fair amount on autosomal dominant hypocalcemia, because again, that's a disorder of calcium sensing receptor biology. I told you that's a mirror image of FHH. Okay, so let's start walking through some of these, and we'll refer back to this algorithm. Okay, so hypocalcemia in the setting of low or inappropriately normal PTH. Let's go through some of these inherited causes. So here we are in this part of the diagnostic family. Inherited causes would include, here we go, excuse me. Here we are in the inappropriately normal. And then I'm sorry, I didn't look at this. June made these for me, so I still haven't studied these. So I'm going to be following this along with you. Again, low PTH, and then we have phosphorus levels that are normal or let's say not predictable. Okay, remember PTH regulates phosphate excretion rates by the kidney, so you'll start to see a common physiologic explanation for the hyperphosphatemia here. It's the low PTH that's driving the impaired phosphate excretion. Remember again, PTH mediates apical transport through the sodium phosphate cotransporters, right? So low PTH would be associated with avid phosphate reclamation by the proximal nephron. Okay, so again, here we go, hypocalcemia with low or inappropriately normal PTH. And then our first one that we're going to discuss is this autosomal dominant hypocalcemia. In this scenario, these patients will present again with PTH that is suppressed, phosphorus that's high normal. Let's talk about pathophysiology first, and then the presentation will make sense. This is a gain of function mutation in the calcium sensing receptor, right? This is the mirror image of the familial hypocalciuric hypercalcemia, which we talked about, right? So again, if I have a gain of function mutation in the calcium sensing receptor, and I'm residing on a parathyroid secreting cell, right? If again, this is a gain of function mutation, then I need lower calcium concentrations, right, in order to stimulate the calcium sensing receptor. That stimulation will lower PTH release. And so these patients will have low PTH and hypocalcemia. Okay, low PTH and hypocalcemia. So again, calcium sensing receptor is a master regulator of PTH, which is a master regulator of serum calcium. Okay. We will talk about this feature, hypercalciuria. I suppose I need to create the building blocks for this, right? And this will revolve around some of the conversation we've had previously for FHH, right? So what does a gain of function mutation of the calcium sensing receptor do with tubular transport of calcium, right? If I have a gain of function mutation of this calcium sensing receptor, then my nephron would be presuming that calcium is in excess, right? If calcium is presumed to be in excess, then the reclamation of calcium would be downregulated, right? If the reclamation of calcium is downregulated, then my calcium excretion rate will be increased, right? These patients will have hypercalciuria. They'll tend to have hypercalciuria. And that contrasts with familial hypocalciuric hypercalcemia, right? So it's all making sense. Okay. This becomes clinically relevant as you treat an autosomal dominant hypocalcemic patient, right? How do we treat an autosomal dominant hypocalcemic patient? We don't have very many options. We basically have to give them calcium. We often have to give them calcitriol, right? Why do I have to give this patient calcitriol? Well, predictably, a low PTH would decrease 1-alpha hydroxylase activity, right? PTH is a regulator of 1-alpha hydroxylase, right? So if PTH is suppressed in this scenario, I will tend to have relatively low calcitriol levels or intrinsic calcitriol production. And so I tend to give these patients calcium plus calcitriol. What happens if you give a patient calcium plus calcitriol and they're hypercalciuric or tend to be hypercalciuric, right? Or their nephron is signaled to be hypercalciuric. Well, they'll become more hypercalciuric. So the side effect of treating an autosomal dominant hypocalcemic, indeed, a side effect of treating all primary hypoparathyroidism patients, okay, is a predisposition to hypercalciuria. And so in those scenarios, we have to keep the calcium in the low normal range or even slightly abnormally low, right? Red, but not too red, right? So 8.1, 8.0. And we keep it there. Why? Because these patients are predisposed to hypercalciuria. Often as well, we give a thiazide, right? That helps the calcium stick. We're treating them with calcium calcitriol. If they're peeing significant amounts of it out, that also will tend to keep the serum calcium low. So we give them a thiazide in these syndromes. It's most important with autosomal dominant hypocalcemia because this has a a significant second hit for the hypercalciuria that's manifest, right? Having low PTH itself will tend towards hypercalciuria, right? We've talked about PTH regulation of calcium transport in the distal nephron, where it's most well explained. There's PTH receptors in other segments of the nephron as well, including the thick ascending limb. But if again PTH is low, right, then I'm decreasing the activity of TRPV5. Calbindin levels are downregulated, and then the apical transport of calcium through this calcium ATPase is inhibited, right? So patients with low PTH are predisposed to hypercalciuria. If you also have this gain of function mutation of the calcium sensing receptor, that tendency to hypercalciuria is magnified. But again, most patients with a hypocalcemia from a low PTH will be predisposed to this hypercalciuric complication, kidney stones. Okay. All right, so I think we've talked about the clinical presentation in a fair amount. These are typically mild degrees of hypocalcemia because it's a single mutation, right? If you have a double mutant, these patients will present with profound hypocalcemia in infancy, but the adult with a single mutant allele will have a milder degree of hypocalcemia. And this syndrome is going to be in the differential diagnosis for any patient with high hypoparathyroidism and low serum calcium. So you're going to go through this differential as you think about post-surgical. Well, that'd be pretty obvious. If somebody had a surgery, you won't be thinking about autosomal dominant hypocalcemia. But if you have a patient with one of the polyglandular autoimmune hypoparathyroidisms, this will be in the differential diagnosis. Okay? Um, Hypomagnesemia and hypokalemia, which are typically mild, can also be manifest in these syndromes. I've already anticipated this conversation, so hopefully I can move quickly. We talked about high magnesium being sometimes a feature of FHH. So here the mirror image continues, right? In this case, magnesium can be low in these scenarios, and it comes back to thick ascending limb, maybe some of this just paracellular transport of magnesium, which is gated by, uh, uh, which is regulated by calcium sensing receptor. We talked about claudins in the proximal tubule, not just the claudins in the thick ascending limb, right? So if I have a gain of function mutation in the calcium sensing receptor, gain of function mutation of the calcium sensing receptor, you have to think of this kind of inverse. It's a bit of a judo flip, claudin affecting claudin 16, claudin 14 affecting claudin 16. Just think the net effect of activation of the calcium sensing receptor is reduced paracellular transport. Okay, net effect of activation of the calcium sensing receptor, reduced paracellular transport, and so I'll tend to waste magnesium. Okay, opposite will be true in the FHH patient, right? This would also tend to have a little bit of K wasting, just like Bartter syndromes tend to have a little bit of K wasting. Okay, all right. Let's move on. Evaluation will be often through genetic testing now that we have that very easy access to genetic testing. That's where the diagnostic confirmation or the confirmation of the diagnosis is ultimately ending. Treatment, I mentioned, really calcium supplements, calcitriol, and thiazide therapy, right? I've described the reasons for that. I don't think we need to go through that text any further. Any questions before I move on? Okay, so this is a scenario, familial isolated hypoparathyroidism. Granted, many of these hypocalcemic syndromes that are inherited, other than this autosomal dominant hypocalcemia, are going to get pretty esoteric. Okay, we're going to go through DeGeorge's syndrome, if you remember that from medical school, one of your brachial cleft, defects where you have problems with thymus and also derivatives of these brachial clefts, including the parathyroid glands. Okay, so we'll move quickly through some of these esoteric things, except to emphasize some of the biology, right? So pathophysiology involves around a transcription factor, which is important in parathyroid gland development. And, sometimes it's a mutation in the PTH gene itself. If you know that underlying pathophysiology, one would predict the presentation hypocalcemia, and in this case, hyperphosphatemia, right? Hyperphosphatemia will be manifest because that PTH is low. All right. Similar kind of story in many respects. These patients with DeGeorge's syndrome have a inherited defect in one section of chromosome 22, and that deletion results in a number of phenotypic abnormalities, including cardiac abnormalities, thymic hypoplasia, parathyroid gland hypoplasia, some problems with facial development, as well as palatal abnormalities, which are possible, right? And again, these patients will have hypocalcemia, low PTH, hyperphosphatemia. Moving on to, I hope, yeah, just one last genetic disease, this uh, well-named syndrome of hypoparathyroidism with deafness and renal disease. Well, we can see that this patient has hypocalcemia with deafness and renal disease, a sort of non-specific catch-all term, renal dysplasia, which can have a number of phenotypes. There's a lot of dysplastic syndromes of infancy that can that are characterized by ear and kidney abnormalities, sometimes hypoplastic external ears. But that is a theme that you should remember, that this link between ear and kidney shows up in a number of genetic diseases. We've talked about some that are conduction defects of hearing. Here are sort of um, is also another deafness syndrome, but you also can have hypoplastic ears and various abnormalities and development of the external ear and kidney disease. So here's an example of one of those, or another example of one of those. This is another defect in a transcription factor that regulates parathyroid gland development, kidney development, and inner ear development. Okay. There are multiple others. I guess I stopped myself at those esoteric forms. DeGeorge syndrome is the one that probably is the most familiar to you. So certainly reasonable to at least review that one. Okay, let's go to the more, the more relevant diseases that you see as an adult nephrologist, and acquired causes are going to be really the most common causes of hypocalcemia. Again, we're still in this branch of the tree where PTH is not sufficiently responsive, right? PTH is either low or normal instead of being high in the setting of hypocalcemia. So sepsis is one of these scenarios in which hypocalcemia is pretty common, right? This is a multifactorial phenomenon. This might have a PTH that is relatively diminished, right? But some will highlight the fact that you have increases in calcitonin in the setting of sepsis, right? You may recall that some forms of risk stratification in pneumonia involve measuring calcitonin. There's a release of calcitonin with systemic inflammation. And so calcitonin is an inhibitor of the peripheral response to PTH. And so you can see that um, this might be a scenario in which PTH would be low in some scenarios, right, where PTH release is inhibited, but in other scenarios in which PTH may not be low, it might even tend to be high. Okay, so sepsis associated hypocalcemia has kind of varying patterns in your PTH, and that's a very common form of hypocalcemia. That's going to be probably one of the most common scenarios that you'll see. Okay, calcimimetics is going to be similar to that autosomal dominant hypocalcemia, right? This is basically mimicking an activation of the calcium sensing receptor, and so PTH release will be decreased. I guess I've reinforced a couple of times. I'll reinforce it again. One of the downsides of using calcimimetics in your CKD clinic is PTH can go up, right? When you start cinacalcet in a patient with CKD4, right? And that's not good. You're always, one can make a strong argument that the primary problem with renal osteodystrophy, yeah, calcitriol deficiency is important, but if you were to correct the phosphorus, most of the abnormalities of renal osteodystrophy will be mitigated, including the calcitriol deficiency. Okay, so when you're treating a patient with pre-ESRD, suppressing their phosphaturic response from PTH being high, their phosphorus can go up. Okay, so that is emphasized in that discussion, and also is emphasized in this I guess we put it under variable phosphorus, but it's emphasized in the biology of the calcimimetics. Okay, hungry bone syndrome. That's another one that you'll definitely encounter. This is a presentation characterized by an abrupt lowering of PTH, either in a patient who has severe sustained tertiary hyperparathyroidism, you send them for subtotal parathyroidectomy or total parathyroidectomy with autoimplantation, or this is a patient with sustained primary hyperparathyroidism who undergoes adenoma removal, right? Those remaining glands, right? 3 glands have been lazy. They've not had to do any work. The adenoma has been doing all PTH release, and so the rest of the glands are appropriately responding, right? Their calcium sensing receptor says calcium is too high. You don't need to make PTH. So with that sustained suppression of the remaining glands, you will have a scenario in which PTH is relatively low in that immediate postoperative period. With time, the PTH secreting, the remaining PTH parathyroid tissue will start to rev up PTH production and release, and then the hypocalcemia will abate. There's also another factor in the pathophysiology, which is the sustained demineralization of bone creates that hungry bone, right? So not only do they have a relative PTH deficiency, right? But they also have a bone that's now saying, gosh, now that you've turned off all this excess osteoclast activity, I can remineralize the bone that has been for years being demineralized. Okay. All right. So these patients often remember your bone as it's remineralizing also takes up phosphorus. And so phosphorus levels can also drop significantly in the hungry bone context. And I think I've talked about this removal of the single hyperfunctioning parathyroid gland, so we can talk about reinforce the presenting features. That is, PTH will be relatively low in this scenario, right? Because again, let's think of it as lazy residual parathyroid tissue. Phosphorus can be low. Magnesium is also bound by bone. So magnesium, bone is one of the main pools of magnesium in the body. So that can also be reduced as the bone is remineralizing. Okay. Management will basically revolve around a bunch of IV calcium. And sometimes you need to use a continuous infusion of calcium. So when I've had a bad patient or a bad hungry bone case, I sort of repurpose the calcium drip from your CRT order. I use that and I just unlink all the other orders. I generally start lower, but I think that would be a reasonable starting place for some of these patients with severe sustained hypocalcemia. Why? Might it make sense to be aggressive? You can certainly be reactive, which is the more common strategy, where you start the person on oral calcium plus calcitriol, and you keep monitoring it, and you give them that, and you keep giving them IV calcium 2 grams. You keep checking the calcium every 6 hours, and then you confirm it's low again, and you give IV calcium. The reason why it makes sense to me to be more aggressive in these scenarios is that you are trying to fill a hole, right? As soon as you give calcium to these patients with sustained demineralized bone, they're going to eat it up. And so it takes a while to fill that hole. And you often need grams of calcium in order to fill that hole. And so being aggressive shortens that duration of that rapid drop in calcium, right? As you fill the hole, your calcium tends to stick. Okay, so let's bring this to the dialysis unit. So in the hemodialysis unit, what the pattern that you'll see in managing these patients that you send for subtotal parathyroidectomy with hungry bone, they'll come out of the dialysis unit on calcitriol plus big doses of calcium. Often it's 2 grams QID and or 2 grams TID and HS, right? You're going to put them on 3 calcium dialysate as well, sometimes even 3.5 calcium dialysate. Okay. And then you have to watch those patients because eventually the hole gets filled, right? And if you give somebody with no renal function massive doses of calcium, well, they're going to be profoundly hypercalcemic at that point, right? Because they cannot defend themselves by excreting the calcium in the urine. So you have to watch these patients. Often, again, you have a lot of calcium up front as you're filling the hole. You got to be attentive because eventually that hole fills. And if you keep pouring in equal amounts of calcium, next thing you know, you're hypercalcemic. Okay. The other part of this is that often the autoimplant or the residual parathyroid gland starts to hypertrophy and produce more parathyroid hormone. And so that would be another reason where they start to, even if the hole is not filled, they can still start normalizing their calcium. Okay. Okay, and maybe one last point on the management because it's common enough, the tertiary hyperparathyroidism. Sometimes these patients with autoimplantation or subtotal parathyroidectomy need to be referred back to the surgeon to put more parathyroid gland in. So most high volume centers have not thrown away the gland. They put it in the freezer, the gland that they took out. And so because they worry that if they didn't have a great vascular supply or they did not put enough gland back into the forearm or they took too much out and they did a total or a subtotal parathyroidectomy, that they need to go back in and put some more in, right? So they keep gland left over. So in a patient who has sustained PTHs that are like, 12, even though their ICALs are, 4 and 3.7, right? It's now month 6 and they're still manifesting PTHs of 15, right? And their ICALs are 4, 3.7. Those are patients that, gosh, I've been trying to fill the hole. I've been trying to wait for this parathyroid gland to start doing some heavy lifting. It should be stimulated to produce, right? The sustained hypocalcemia is a profound stimulus for this residual parathyroid gland. If by 6 months you still have a PTH of 15 in a patient with sustained hypocalcemia, well, that patient needs to be referred back to the surgeon for consideration for more parathyroid tissue reimplantation. Okay. And that's another reason why in these scenarios we don't oversupplement. You want them to be a little bit hypocalcemic because you want that hypocalcemia to stimulate the residual parathyroid gland. Okay. All right. Primary, I think I've talked about acute and chronic. Yeah, over time. All right. Parathyroid, primary hypoparathyroidism. These obviously have a similar pattern again, low calcium, high phos, and PTHs, which are low. The pathophysiology, again, autosomal dominant hypocalcemia can be in the differential diagnosis, but often we see scenarios like autoimmune hypoparathyroidism, which can be um, the sole abnormality or be part of a combination of um, endocrinopathies, the so-called polyglandular autoimmune syndromes. There's a type 1 and a type 2. Here's one other sort of example of the typical nomenclature, polyglandular failure syndrome, type 1. This is a problem with cell-mediated immunity. These patients will sometimes present with candidal infections because of this defect in T cell immunity. They can now produce autoantibodies because T cells are regulating your B cells and plasma cells. And these autoantibodies can target parathyroid glands, resulting in the hypoparathyroidism, adrenal glands, resulting in obviously primary adrenal insufficiency. These patients can develop hypogonadism, and they can also have problems with malabsorption as well. Okay, you recall there are other polyglandular autoimmune syndromes that can manifest with type 1 diabetes, but this is the most common one that can present with the low parathyroid function. Okay. All right. This also more commonly is a post-surgical hypoparathyroidism, which I kind of essentially talked about. This can also not just be the result of a parathyroidectomy gone wrong, but a thyroidectomy gone wrong, right? So when you inadvertently cause disruption to the vascular supply to the parathyroid glands, then that can be another scenario in which I get hypoparathyroidism. Um, uh, Okay. Management, I've talked about, remember calcium with calcitriol, because PTH is needed to activate vitamin D. Calcitriol is often in deficient states or is deficient in these patients. And I don't try and normalize the calcium. I try and keep it on the low end of normal because of that tendency to hypercalciuria. Less than autosomal dominant hypocalcemia because they only have the one hit, the low PTH. They do not have the gain of function mutation of the calcium sensing receptor. So, but they are still predisposed to hypercalciuria. Rarely there may be consideration for recombinant PTH that is available. I mean, we use it actually for osteoporosis treatment for Teo. In pulse form is an anabolic drug, but you can theoretically use it in cases of primary hypoparathyroidism. But there's downsides to that. There are descriptions, at least in animal models, in which you give exogenous recombinant PTH there that in animal models is associated with the development of osteosarcoma. Okay. The beauty of this is that, remember, when PTH is low, and I'm just giving you calcium and calcitriol, you do have the risk of adynamic bone in that scenario, right? PTH activity is part of the normal balance between osteoblast and osteoclast function. And so if I have no PTH, I'm just giving you calcium, there is a tendency to adynamic bone. Similarly, patients with cinecalcet therapy who have PTHs which are oversuppressed or post-parathyroidectomy in dialysis are also at risk of adynamic bone. Okay. All right. Maybe we'll go through this last group. I think I can do that reasonably quickly and just a little bit over time. Hypomagnesemia is a possible cause of hypocalcemia as well. Magnesium is a cofactor for PTH release. So if we're going back to the figure, PTH resides in these intracellular vesicles, right? And the fusion of that vesicle with the cell membrane relies on magnesium for that fusion process to occur. So if I have profound magnesium deficiency, I can have a reduction in PTH release. PTH being low will tend to cause the hypocalcemia. Okay. But there's a couple of other possibilities as well, because magnesium is also uh, a part of, or is a regulator of the peripheral response to PTH. So PTH's stimulus of this osteoclast on the bone relies on normal magnesium as well. So this, let's presume this is a multinucleated osteoclast resorbing bone. So if I have low magnesium, I may have insensitivity of this osteoclast to PTH. So sometimes with low magnesium, you have a PTH which is high. Sometimes because of the peripheral resistance. If magnesium deficiency is profound, usually it's more severe magnesium deficiency that is associated with low PTH. So you have both the peripheral insensitivity plus a primary problem with PTH released by the parathyroid secreting cell. Okay. One point to make, which we'll make in our discussion around magnesium, is that serum magnesiums are not the best measure of magnesium deficiency or sufficiency. And so your magnesium levels may not be that low, and still you may have pretty profound magnesium deficiency. Hypermagnesemia is a scenario in which when magnesium is very high, you can, just like the other divalent cation calcium, you can activate the calcium sensing receptor, right? Magnesium is a divalent cation, calcium is a divalent cation. So if magnesium is very high, you can basically activate the calcium sensing receptor, PTH levels drop, and then calcium gets low. So, okay, so this would be a scenario that you might see in the patient receiving a magnesium drip or preeclampsia. They can get hypocalcemic. All right. Which I said here. Okay. Infiltrative disorders are enumerated here. I don't know that I need to say much about that, right? Processes that infiltrate the neck. I should add here IgG4 related, RGG4 related thyroid disease, which used to be called Riedel's thyroiditis, is a disease in which the thyroid and parathyroids can be replaced by an infiltrative, inflammatory, plasma cell rich, and fibrotic process. All right, questions? Okay, well.